Hi, everyone. It's really great to be here. My name is Ewa Czyz. I'm an associate professor in the Department of Psychiatry. Um, my research focuses broadly on suicide prevention in youth and young adults, and I'm interested in applying mobile technology to understand kind of dynamic processes that are happening in people's day-to-day life that may lead to elevations in suicide risk, and in using technology to inform and to deliver more tailored interventions. So today I'll talk about the use of intensive longitudinal data in suicide prevention research and focusing on more kind of practical issues and considerations when applied specifically in context of adaptive intervention. So I, I, I have seen some of the other talks in these meetings. I know people have talked about adaptive interventions and JEDIs. I think for me, in the past, it was like kind of the idea made sense, but it was always challenging to think about how do we actually take the data that we're collecting intensely and how do we translate them into adaptive intervention. So I will be focusing on this area with respect to suicide prevention interventions, but really you can use these approaches for um, any other topic. So this is our roadmap for the next half an hour or so. I'll do a very brief background. I'll talk about how intensive launch-on data give us opportunities to characterize, predict suicide risk, and then guide personalized interventions. And we'll really dive into issues and consideration with respect to how do we make use of intensive data to inform interventions. And then we'll touch on some protocols specific to at-risk populations, and I'll focus on some examples from our prior work talking about risk management protocols, and hopefully we'll have some time for a discussion. So just starting with an overview, many of you may have seen these statistics. Youth suicide is currently the second leading cause of death in adolescents in the United States. These data on the right-hand side are from nationally representative samples of high school students. They're kind of the most recent data, showing that about 1 out of 5 high school students have seriously considered suicide in the past year, and about 1 out of 11 have made a suicide attempt. And kind of seeing these data year after, they're actually collected every 2 years, but seeing them sort of every time, it's been quite concerning to see that every time we're seeing these rates go up and up and up. On this slides, these are showing number of young people who are seeking emergency department or ED services related to mental health related visits. These are on the right, on the left hand side, and then suicide related visits, so related to thoughts of suicide or attempts. And what's really striking about these data is that we see that there's been kind of a 5-fold increase specifically in suicide risk-related visits in the past decade or so, particularly in adolescents between the ages of 12 and 17, and that's kind of orangey line at the top. And the reason I'm bringing up this slide is because much of my own work focuses on how we can identify and then help prevent recurrence of suicidal thoughts and behavior in youth who have been in the ED or who had been hospitalized psychiatrically. All right, so how do intensive longitudinal data fit into this? And first, let me just briefly review what we mean by intensive longitudinal data, although I do believe that this topic has been discussed in this meeting previously. These have to do with repeated assessments that can capture dynamic information about someone's internal state, so things like thoughts, emotions, behavior, or context in real time or near real time. And intensive data are typically obtained using mobile-based assessments, using self-reports. So this could be once daily or multiple times per day, such as using EMAs or ecological momentary assessments. These data can also be collected passively without any active participant input using wearable sensors or mobile-based sensors. Now, when it comes to suicide risk, intensive data can improve our understanding of suicide-related phenomena as they're happening in everyday life, aid in prediction of suicide risk using really short timescales, and also informed delivery of timely support. So I'm going to mention just a few studies from our lab to highlight some of these benefits before we dive into kind of the practical considerations. So this is one of the first studies that we did in this area. This was several years ago now. And this figure shows relative variability in day-to-day suicidal thoughts in adolescents who were followed after inpatient hospitalization. And a really simple but important question that intensive data can help us answer is, what do suicidal thoughts or ideation, which is denoted as SI, even look like in everyday life? And so these figures show us that thoughts of suicide are actually quite dynamic and change from observation to observation. So the individual lines you're seeing shown in different colors, these represent each person's deviation from their standardized mean, which is set to 0. So about 50% of the time, suicide ideation ratings were different from next observation. In our case, this was next day rating, but at least one within person standard deviation. So this just means that ideation really ebbs and flows and is far from being static in day-to-day life. Intensive data have also helped us kind of see some interesting patterns related to the course of suicidal thoughts. So on this slide, we have two figures showing suicide ideation frequency in adolescents. On the left, this is shown in an inpatient sample, and these youth completed 5 EMAs during the course of their hospital stay. And then on the right, this is shown in adolescents who were followed daily for 1 month after discharge. And the figure shows that suicide ideation is not really experienced in a uniform way when we're sampling it repeatedly, but instead follows these 3 different groups in terms of severity of thoughts of suicide. There's the low group that's shown in blue, initially high, but then rapidly declining group, and that's shown in red. And then this really persistently high group, which is shown in black, with about 30% of adolescents across the 2 samples showing this kind of persistently high on unrelating thoughts of suicide in everyday life. And so ideally, we should be providing much more personalized support to adolescents at risk for suicide that can better address these kind of different, but also changing suicide risk states as they're happening in day-to-day life. So in addition to characterizing what thoughts of suicide look like in day-to-day life, another advantage of intensive data is to identify when suicide risk is elevated. So this slide shows a prediction model a team published on, which is structured as a kind of like a decision tool that was optimized with a multi-level machine learning approach, which was intended to detect the occurrence of next day suicidal thoughts in adolescents who were surveyed after hospitalization. We can see kind of the different paths that predict presence or absence of suicidal thoughts, which is shown as a yes or a no at the bottom of this figure, based on different combination of risk factors and also based on different thresholds of these factors. So one possible application of such a decision tool could be to flag, for example, each day, whether suicidal thoughts will occur on the next day, and if so, offer an intervention. And so this really brings us to this idea that intensive longitudinal data can be used to predict elevations in suicide risk states and inform when and for whom timely support should be offered, which is applicable to adaptive intervention designs. I know that this has been touched on in these meetings before, so this is just a very brief review. An adaptive intervention is a type of intervention that uses empirically based guidelines for delivering tailored treatment. So practically speaking, an adaptive intervention specifies if, when, how, and for whom intervention should be delivered or adjusted at critical points in time. Just-in-time adaptive intervention, or JEDI, is an intervention in which rapidly changing information about someone's internal state or their context is used to decide whether and how to intervene in real time. So in a JEDI, intervention options are adapted on a relatively fast time scale. So this could be every few hours or daily. In contrast, in a standard adaptive intervention, Intervention options are adapted on a relatively slower timescale. So this could be every few weeks or even months. In both cases, intensive data are well suited to help protocolize the delivery of adaptive interventions by specifying something called a tailoring variable, which you'll hear me refer to repeatedly during this discussion, which are conditions under which to deliver or augment interventions. So I'm going to be talking about how this might work for suicide-specific interventions again, but many of these concepts and considerations for how to make use of intensive data can really apply to other areas. All right, so to make this a little bit more concrete, here are two examples of adaptive interventions. At the top, we have an example of a standard adaptive interventions where adaptation happens on a slower time scale. We may be offering some kind of an initial intervention, and then we're using intensive data to monitor functioning each day or repeatedly throughout the day to subsequently determine, and this could be at the end of the first week or maybe again at the end of the second week following that initial intervention, to figure out who should be offered what type of additional support. And in this case, more intensive intervention might be offered to individuals who, based on our monitoring, are showing concerning elevations in suicide risk. At the bottom of this page, we have an example of a Jedi where adaptation, it's a very simple Jedi for those of you who know Jedis, where adaptation is on a faster time scale. So here we are monitoring functioning with intensive data. Maybe this is daily, maybe multiple times a day. But instead of waiting until the first or the second week to check if someone needs additional support, we might be checking risk status more frequently. Maybe this is daily. And if risk status is determined to be elevated at the end of each day, we are providing an intervention prompt, and otherwise we are not offering additional support. And again, this could be on a faster time scale. This could be multiple times a day that we're checking on the elevated risk. Now, when we look at the right-hand side of this slide, regardless of whether intervention adaptation is following the slower or faster time scale, these adaptations are occurring at specific decision points via decision rules that specify under what condition, and that's called a tailoring variable, we should be providing an intervention option or not. And a tailoring variable is based on ongoing information about someone that's used to determine next intervention option. So we'll touch on these examples next and how we might practically use intensive data to derive these tailoring variables that are guiding adaptive interventions. And those of you on the call, and I think I saw a couple of people who are adaptive intervention experts and are in labs that deal with adaptive interventions. I know there are other adaptive interventions, but we're kind of using a more simplified example for our purposes. All right, so we'll start with an example of an ongoing trial in our lab. It's a sequential multiple assignment trial, or SMART, which is used to inform a standard adaptive intervention. Okay, so I know there's quite a bit happening on the slide, but I'll walk you through the important points. In this SMART, we're focusing on developing adaptive intervention for psychiatrically hospitalized adolescents. In this design, all youth receive an in-person safety planning intervention that's shown kind of in blue on the slide during hospitalization, and then we are randomizing youth to different intervention strategies after discharge. So we're randomizing them up to 2 times. Initially, half of the youth are randomized to supportive text messages that are offered for the first 4 weeks after discharge, and half are not. All the youth are monitored daily with electronic surveys to track how they are doing. And this may sound familiar to a hypothetical example. At the end of the first week, and again at the end of the second week following discharge, we are checking adolescents' response status. So we're checking whether teens are showing early signs of moving towards a suicidal crisis. So adolescents who are flagged as non-responders based on a pre-specified tailoring variable and are thus presumed to benefit from additional support, those youth are re-randomized to receive one of 2 augmentation strategies. So that is either booster phone calls or communication with a counselor using a web-based portal. that's similar to a patient portal. So youth who are classified as responders and are presumed not to be headed towards a crisis are not provided with any further intervention. Looking at the right-hand side, this SMART has 4 embedded adaptive interventions. So each begins with an initial safety planning intervention and then includes different sequences of post-discharge support depending on whether or not someone is a responder or a non-responder. And ultimately, using this experimental design, we are interested in learning which adaptive intervention is best and for whom. But how do we come up with this tailoring variable for the study, which is used to determine if someone is a responder or a non-responder, whether they need more or less support? And so this is what I'm going to show you next. And how we kind of went about that process, which actually is more simple than I originally feared. We used existing data from a prior study with a similar population of psychiatric hospitalized adolescents who were followed daily with surveys after discharge. And the surveys were assessing different theoretically and clinically relevant constructs associated with suicide risk. So things like hopelessness, negative affect, thoughts of suicide. And for each of the construct that we assessed in the daily surveys, we created very simple features, and those could be more complex, but we focused on simple. And that included the mean and the variance that we aggregated first over the first week, which corresponds to our first decision point, and then again over the first 2 weeks, which corresponds to our second decision point in the ongoing SMART. And we wanted to know which of these features or their combinations from these various constructs best predict a future suicidal crisis. So that's ultimately what we're trying to prevent in this intervention. And we define a crisis as a suicide attempt, an ED visit, or rehospitalization related to suicide risk. And I'll show you in a bit that we had a pretty simple approach. It was a 3-step process involving a series of receiver operating curve analyses, or ROC curves, to determine the best tailoring variable that would be used to flag someone as being at risk for a future crisis with reasonable predictive accuracy. And here we wanted an AUC of at least 0.80. That sort of corresponds to a larger effect size. This is an abbreviated table because I couldn't really fit all the possible models that we ran in this process. But essentially, the process was as follows. In step 1, we screened out predictors, which again were aggregated kind of over the first week or the second week, corresponding to our decision points, that had a weak association with the outcome of a future suicidal crisis. So we retain predictors for further investigation if their standardized odds ratio or if the model's AUC was at least medium in magnitude. So you can kind of see how we defined it. It was a pretty low threshold because we did not want to prematurely get rid of predictors that had some meaningful association with the outcome. And again, each model represents a row, and the slide shows just a portion of the models. In step 2, we examined different combinations of these pre-selected predictors or their features. And the goal is to identify a model that would be useful in terms of effect size. So again, this kind of AUC of at least 0.80 in identifying a future crisis. So in this step, we determined that model 4 was the best performing model based on the highest AUC, and we decided to select that model.
I have a question. Were the predictors per participant, calculated per participant, or across the
Yes.
population?
So we calculated them per participant. So every participant had their own values.
Predictions. Okay, thank you.
So in step 3, we are showing a prediction rule, which is circled in red, that's based on the best performing model that we selected in step 2. So here, based on the combination of different predictors from the best performing model, this is the resulting predict probability that would be used to flag a person as being at risk of experiencing this future crisis. And then thinking back to our SMART, we could use this prediction rule to flag someone as being a responder or a non-responder to determine what they might need next. And it's, again, I just want to highlight that it's important to choose a different tailoring variable, different threshold, depending on your decision point. So in our case, we have a different threshold that we're using at week 1 and a different threshold that we're using at week 2 because different thresholds were had a different association with our ultimate outcome that we're trying to prevent of a suicidal crisis. All right, I'm going to keep zooming because there's a bit more too that I wanted to show you. Next, we're going to talk about how intensive data can be used to guide a Jedi. So this is our Jedi from our prior example. Just as a reminder, we're using intensive data to monitor daily elevations in risk. And if elevations detected, we're providing a tailored prompt. Otherwise, we're not offering an intervention prompt. And how might we go about defining this tailoring variable? And how can we flag that someone's elevated risk? So I'm going to, again, lean on existing data for the second example. Here's a prior study our group carried out with young adults who were followed for 8 weeks after discharge from an ED. In this study, we collected 4 EMAs per day, and then we also collected passive data with a Fitbit device. Our objective in this study was to predict presence of next day suicidal thoughts, more for the sake of prediction, rather than creating a tailoring variable per se, but the process would be very similar for identifying the best tailoring variable for a hypothetical Jedi. So in this study, as I mentioned, participants responded to EMAs. We assessed approximately 23 different constructs across different cognitive, affective, behavior risk factors. So this could be, agitation, hopelessness, burden, thoughts of suicide, different negative, positive affect. Some of these constructs were assessed with 4 times a day, and some were assessed only once per day. So, for example, things like sleep, we only assessed in the morning. Passive sensing predictors had to do with sleep, activity level, heart rate, and those were assessed continuously. So it's a lot of data, and how might we go about processing all these really complex data to arrive at something that's really a more concrete as a tailoring variable. So in our case, we process EMA passive variables to be summarized at the day level, since we were interested in detecting presence of thoughts of suicide the next day. But they could be summarized in a different way. They could be summarized in within a day, in smaller blocks of time. We used EMA and passive data to create nearly 100 time-varying features for each person and for each day. So these features included prior day average score for each contracts of interest. So for example, this represented overall functioning on a prior day. So how hopeless or how sad was I on the prior day? The second set of features had to do with cumulative time varying means, which sort of represent on average functioning up to any given day in a study. So this was a kind of a moving average, if you will, and in a way kind of represents how hopeless or how sad have I been up to today. And then tomorrow, how hopeless or sad have I been up to the next day in the study. Another set of features had to do with change from the cumulative mean. So today, am I feeling how much am I deviating in terms of higher or lower hopelessness relative to how I have been doing up to a given point in time? And then finally, we had a set of features that had to do with maximum score of a given construct for a given day. So what is sort of like kind of the peak hopelessness or peak sadness I had on any given day in the study. So starting with, and this was done for all the variables, including passive variables. So starting with over 100 features, we subsequently wanted to reduce them. It was a lot of features. So we applied PGEE models, penalized generalized estimating equations models, to select ones that had the strongest association with the outcome of next ideation. And when I say we apply them, I really mean that our wonderful data analyst, Lauren Zimmerman, applied those because she is just a really wonderful, skilled data analyst who knows how to do these models. And using this pre-selection approach, we retain about 35 features, which seemed a little bit more manageable. The features were then examined in multi-level classification and regression tree analysis models, or CARTs. So we considered one card for EMA features only, one card for passive features only, and one combined card that included both EMA and passive features. And there were some complications in figuring out how do we do cross-validation, given that the data have multi-level structure, but we landed with a five-fold blocked cross-validation approach with multiple repeats. And I do want to emphasize that there may be different and even more complex ways to approach processing and the analysis of intensive data. There could be different, more complex machine learning models that could be applied. We landed on cards because we were interested in high interpretability, and that's really what we try to prioritize for our purposes. I'm not going to show you the actual results because that's not what we're trying to do in this talk. I think we're focusing more on the process. But I will just mention that for those interested, that features that were derived from passive sensing were not at all helpful in identifying next day thoughts of suicide. So it was interesting, but also consistent with prior work. And so our best performing model was derived from EMA features, the self-report features, and that's what you're seeing on this slide. This is the best performing CART model, which had a pretty decent predictive accuracy AUC of 0.84. And what you're seeing is kind of a decision tree showing how the various EMA features and thresholds of these features come together to predict next day thoughts of suicide. And practically, this translates into asking participants only 3 questions, which is quite a reduction from the 23 questions or so that we started with. And how does this relate to our hypothetical Jedi? Well, the idea is that this resulting decision tree could be used to monitor daily elevations in suicide ideation and inform our decision rule for the Jedi. So for example, if we detect that suicide ideation is going to be present, in this case on the next day, we would use this information to offer a tailored intervention prompt as part of the Jedi. And the idea is that the intensive data can be processed to produce these, pretty feasibly to produce these useful tailoring variables that are highly interpretable, that can be applied to guide the delivery of personalized interventions. I will highlight the last example of how intensive data can be used to inform adaptive interventions, and this is from an ongoing trial that has yet to begin, but this is an RCT that has an embedded micro-randomized trial that I'm MPIing with Dr. Adam Horowitz, who's a close collaborator and a fellow faculty member at the University of Michigan, Department of Psychiatry. And what we're doing here is we're trying to develop a just-in-time adaptive intervention for adults who are at risk for suicide, who are seeking ED services for suicide risk. This intervention combines a brief safety planning intervention that's provided in the ED, and then has a text-based support program that's offered for 4 weeks after discharge. And we're using the MRT, which I believe has been mentioned in these talks before, but just as a brief reminder, it's a form of an experimental design that's used to inform Jedi. So a SMART is used to inform more standard adaptive interventions, and an MRT is used to inform Jedis. The MRT portion in our study is highlighted in this yellow box you can see in the middle. And as part of the MRT, we're randomizing participants twice daily, in the morning and in the evening, to either receive or not receive messages. And when randomized to receive a message, we are further randomizing participants to different levels of message personalization. That's based on their initial safety plan that was completed in the ED, or based on dynamic personalized feedback that's referencing participants' recent functioning that participants are reporting via twice daily surveys. So the surveys are not shown in this figure, but essentially participants are completing a survey prior to each randomization. That's shown as the R in the yellow box. So there's a survey, then there's randomization, and then in the evening there's a survey and there's randomization. We don't have a tailoring variable selected here, so this is why I wanted to highlight this example. But the goal of the MRT itself and the intensive data that we're collecting alongside is to develop a Jedi. So specifically in this case, we'll be able to answer not only if, but when it may be beneficial to deliver supportive messages, and also what type of messages in terms of degree of personalization to improve post-discharge outcomes in this population. So this is another way that intensive data can be used to inform an adaptive intervention, particularly if there are no kind of prior data that someone can use or lean on to develop a tailoring variable that's more readily used in a Jedi. So to recap this portion, we discussed three examples of how intensive data might be used to construct tailoring variables and inform decision rules that guide intervention adaptation. Whether we're applying these ideas to suicide-specific interventions or to other areas more broadly. In the first two examples, we relied on existing data to arrive at more readily interpretable tailoring variables for standard adaptive intervention and then for hypothetical Jedi. And in this last example, showing an MRT design, intensive data will be used to evaluate if and when supportive messages may be beneficial, which eventually will guide the construction of a Jedi following ED discharge. Finally, I wanted to spend maybe just 5 or 10 minutes to go over a couple of examples of intensive data protocols with individuals at risk for suicide, with attention to the issue of how we might respond if participants endorse suicidal thoughts or suicide attempt as part of EMAs or daily surveys. And this could really be its own presentation. So I'll highlight just a couple of examples of risk management protocols our group has used with adolescents and then with adults. So this first example encompasses 3 separate but similar studies with adolescents who are hospitalized for suicide risk and then who are followed with daily surveys following discharge, typically for 1 month. For all 3 studies, we were interested in using daily surveys to track response to an intervention that was provided before discharge and assess relevant constructs such as suicidal ideation and suicide attempts. The way we went about data collection in these studies was to send a link to a survey that was sent by text message once a day. So this was not an app. This was done once in the evening, and participants had about 3 hours to complete these surveys. We decided on the once per day assessment because the design fit our research questions that had to do with, how are people doing after this intervention? And also because the approach was more feasible in terms of being able to implement our risk management protocol, which I will describe next. So in all 3 studies, we asked adolescents about presence and severity of thoughts of suicide, as well as presence of a suicide attempt in reference to the last 24 hours. For our risk management purposes, we had a 2-tiered system. So first, when any thoughts of suicide were reported, there was an automated pop-up message at the end of the survey encouraging teens to seek support and reminding them about crisis resources. As part of the second tier, when adolescents reported thoughts of suicide with any intent or planning, or if they reported a suicide attempt in the last 24 hours, a research staff member called that adolescent and their parent that same evening to obtain more information and to provide recommendations. And this was done in consultation with a licensed supervisor. So in other words, we didn't contact participants each and every time they had any thoughts of suicide, but we did when suicide risk was more elevated. It's really critical to, and I'm sure this is preaching to the choir, to do a really thorough informed consent process. So we discussed these different scenarios and what action might be taken by the research team with both teens and parents at the time of the consent. So what did we find? Well, we found that the vast majority of adolescents in the studies disclosed thoughts of suicide over the month that they were followed. So about 70 to 80% of the sample had some thoughts of suicide. And thoughts of suicide were reported about 25 to 40% of the time. At the same time, our research team had to make direct phone calls to participants when that risk threshold was higher as part of our second tier in relatively few cases. So this was a handful of times that represented about less than 1% of the time. So the two-tier system was quite manageable. However, it's important to mention that it was still resource intensive because we still had to have a research team member on call each evening, 7 days a week, for the duration of data collection. Another interesting point that I wanted to highlight, the first study in a set of these three that I mentioned for the youth was kind of the first study of its kind in terms of surveying teens right after hospitalization and asking directly about thoughts of suicide. And so we weren't quite sure what to expect with that study. But one of the kind of interesting things we learned as part of that very first protocol we piloted is that the majority of the youth report that they either felt better or neutral after responding to the daily surveys, which was encouraging as I mentioned, had some initial concerns if the protocol would potentially be upsetting or we weren't quite sure what to expect. All right, and lastly, I'll describe a second example of an intensive protocol that involved young adults who were followed after an ED visit. So I described the study in the previous context of developing a tailoring variable, but now we'll chat a little bit about how we managed disclosures of suicidal thoughts and attempts in the study. So again, this involved adults who were followed for 8 weeks after an ED visit, and we collected 4 EMAs per day. There was a wearable Fitbit sensor, and also there was passive monitoring of a phone use. At the end of the 8 weeks, participants took part in a kind of a traditional phone assessment. Oops. So in this study, we asked about thoughts of suicide 4 times a day. In reference to the last hour, we also asked about thoughts of suicide at the very end of the day in that last EMA concerning the entire day. And we also asked about thoughts of suicide, suicide attempt once a day. But unlike in the adolescent studies I mentioned, our risk management protocol was very different. So as part of the study enrollment and consent process, we made it very clear that we're not looking at EMA responses until the study is over. We used for data collection, we used an EMA mobile app. And the app had information about how and when to contact the study team about study-related issues, as well as about contacting crisis resources should the participant feel distressed or be experiencing a crisis. And whenever participants reported any suicidal thoughts or suicide attempt, they received an automated reminder within the app that EMAs are not being monitored and that the study by the study team, and were provided with a statement encouraging support seeking along with crisis information. So again, unlike in the adolescent study, we didn't make any calls directly to participants. So what do we find in terms of the protocol itself? There are a couple of takeaways. First, thoughts of suicide were reported at a rate of about 15% of the time. This corresponded to over 2,000 instances of thoughts of suicide that were endorsed by about 80% of the sample. And it would have been nearly impossible to respond to these disclosures if we were calling participants directly. So overall, given that these were adults, we felt this was a reasonable approach. Second, I mentioned that we did a phone follow-up at the end of this 8-week protocol, and we found something that's interesting that I wanted to share, which is that while the vast majority of participants reported feeling either positive or neutral after completing EMAs, about 12% indicated that they felt worse after completing EMAs. And I think this is something that we should be thinking about, that there's this subpopulation of individuals for whom taking part in these intensive protocols could be more negative rather than a neutral experience. And at the very least, it's critical to be very clear with participants that they always have an option to stop participating anytime, which I know is part of consent forms, and our staff, do a good job conveying that information. But I feel like there could be an extra step we take in research studies like this to express that, especially if someone is if their thoughts or feelings are impacted in a negative way, that it may be wise to that they have an option to stop participating. All right, so to recap, this portion related to risk management, it's important to have a well-defined approach for responding to participant disclosures related to thoughts of suicide or suicide attempts. A study team may decide to be available to call participants who make these disclosures and/or display an automated message encouraging support seeking. The more conservative approaches that involve calling participants directly may be warranted, especially with minors and during high-risk periods. The protocols are feasible, as we found. However, they may still be very resource intensive, even if the volume of actual calls is low, as we found in our prior work. And when considering different risk management procedures, consulting with colleagues is really just as critical, especially if preparing to implement a protocol that's in a new setting or with a new population. And this was one of the things that I feel like I really benefited from talking to different people and trying to figure out something that felt both feasible but also appropriate to a given population or a given setting. All right, so as a final slide, I wanted to acknowledge the many collaborators who are listed here who are involved in this work over the years, the research staff, volunteers who are part of our YDSP and MHEL labs, and would like to acknowledge the funding sources that made this work possible. And this includes funding from NIMH, the American Foundation for Suicide Prevention, the Francis and Kenneth Eisenberg Research Award, and the Michigan Institute for Clinical and Health Research. And here's my contact information. If you'd ever like to reach out, happy to answer a question and happy to chat now as well.